Well, welcome back to this Doc Talk on screening, risk assessment, and active surveillance for prostate cancer. And in this segment, Dr. Eric Klein is going to take us through a fairly typical patient experience and illustrate the role of screening and assessment of risk of progression in which patients are good candidates for active surveillance. So Eric, it's all yours.
So great. So first, my colleagues have not seen this case, but guys, it's a real case from my practice, and there aren't any curveballs in here, okay? So we really just want your thoughts about this. A very typical man that you've seen in your practice over and over again, 53 years old, healthy, normal digital rectal exam, estimated volume about 50 grams, no family history of prostate cancer, mild lower urinary tract symptoms managed effectively by an alpha blocker, and no erectile dysfunction. So I actually saw him initially in November of 2012 with that PSA history. He said that he'd had PSAs prior when he was in his mid-40s, but he doesn't really know what they were. So his PSA's been relatively stable, hovering around 5. And the question is that he asks is, does he need a prostate biopsy? So, Jerry, what are your thoughts about this, knowing all the data that we know about PSA and screening for prostate cancer?
Well, he obviously has made the decision to be screened.
Yes.
And now that we know that his PSA is abnormal, and that's really, he's probably in the top 10 to 15 percentile of men in his age group for that PSA. So to me, that says that he has a much higher than average risk of having or dying of prostate cancer. So yeah, I would recommend a biopsy on him.
So Andrew, look at his PSA velocity. It's basically flat over 18 months. Does that have any predictive value on whether or not you would want to biopsy this gent?
That's a great question. I mean, there's a lot of controversy about the value of PSA kinetics as a screening test. I'm not terribly convinced by that data. I think what's more important here is the absolute level of his PSA, and that the fact that it is stable over time, meaning that there aren't just brief fluctuations where it spikes up to 5 and then normalizes. So I think the absence of changes in the PSA over time, to me, is not a protective factor here. It's more the absolute value is very high for a man of this age.
Okay, so you both recommend biopsy.
Yeah.
Right,
Okay.
and I will say in PCPT, I like that study, PSA velocity was not an independent predictor.
Right, that's correct, when you looked at all the other parameters. Okay, what if I tell you this? He had a negative biopsy back in 2011. So he had a negative 12-core peripheral zone biopsy. I did not do it, but the slides were reviewed here and are negative. Does that change your opinion now? He's had a negative biopsy, a flat PSA velocity, and really no change in the absolute value of his PSA. So he still wants to know if he's got prostate cancer. What do you do in this circumstance?
A first-time random biopsy done under ultrasound in a doctor's office misses about half of the significant cancers that are in that prostate. And furthermore, his prostate's fairly large, it's 50 grams. So you would even potentially miss more. And so in my practice, I either obtain additional markers, maybe PCA3, or an MRI scan, because either one or both of those may tell me to definitely do a biopsy and where to do the biopsy.
Got any sense of which of those might be better?
Right now, I tend to think MRI is better than PCA3, but that's just an opinion.
Andrew?
Yeah, I mean, I agree with Jerry. I think that we know that about 25% of men after a negative biopsy who undergo a repeat biopsy, regardless of the PSA changes, will have evidence of cancer. And a substantial number of these folks are going to have some high-grade disease. So I agree with Jerry. I think certainly the thing that would concern me about this patient is his young age and his very high PSA level, and I would still be suspicious that he may be harboring some aggressive cancer.
So I actually have been pretty impressed with the value of PCA3 in this circumstance, actually, both in the negative biopsy setting and in the primary screening setting, and I'll show that data in a minute. So his PCA3 was 55. We tend to think of the FDA-approved cutoff for PCA3 of around 25 in the negative biopsy setting, but in reality, it's a continuous risk variable like PSA is. So would this push you to biopsy now?
Yeah, I routinely do PCA3s in these guys.
And I just want to show one instructive study I think that was done in Europe. In the primary screening setting, this was a prospective study of men who'd had PSA, were going to undergo biopsy, where PCA3s were collected beforehand. And if you look at the area under the curve on this ROC, PSA3 had the best predictive value compared with PSA alone or free PSA and so forth. So I use it to decide on biopsying men like this who have indeterminate PSA values. I don't know, do you guys use it in the primary screening setting or only in the FDA-approved indication of negative biopsy?
Yeah, I infrequently use it as a primary screening tool, but certainly in this scenario I do use it. Even using it active surveillance though.
Okay. So here's his biopsy entry. Gleason's 3+3 and 2 out of 12 cores in very small volumes, less than 1 millimeter and 1 millimeter. So his PSA density is 0.1. So he meets Epstein criteria for very low risk disease. So is he a candidate for surveillance?
Yeah, I think certainly that would be one of the options that he could consider in addition to treatment.
Okay. Jerry, you would agree?
Yeah, I agree. You know, I'm reassured it's his second biopsy. I think a second biopsy is unlikely to miss significant cancer, you know. So, yeah, he, on the face of it, is a great candidate for active surveillance, but I would personally like to see an MRI because, again, I'm a little nervous, relatively large prostate. Is there an anterior tumor that these biopsies aren't reaching?
So here's his MR, and it was read as negative.
Okay.
And high quality study done here, you know, and a really good radiologist. So does the fact that someone has a negative MR mean that he doesn't have high-grade prostate cancer? What's the evidence to support that assertion by people who are advocating the use of MR and avoiding biopsy with a negative MR?
That's a great question. I think that MRI is improving, but by no means is it perfect. And in fact, most of the high-grade cancers that are identified actually are of low probability lesions on MRI.
Yep.
So if you have a high probability lesion on MRI, it's very highly likely to harbor some high-grade cancer. But unfortunately, it's the sensitivity of MR is not terribly good.
Yeah. I agree with that. I mean, the negative predictive value, the value that a negative MRI, it's not high enough to not do a biopsy.
Okay. And I agree with that, and I think there are people on the circuit who are a little bit over-enthusiastic about this, although I agree, I think it looks very promising. Okay, so he had a digital rectal exam and PSA at 6 months. His DRE was unchanged. His PSA was up a little bit now, 6.8. So it went from about 5.2 to 6.8. What's the significance of that over the course of a year?
I think Andrew called that PSA-itis, probably. Maybe it's from your biopsy. I would try to talk him down out of any anxiety, personally.
Well, he's pretty anxious about it. Oh, my God, my PSA is going up.
Well, again, I think that these patients really do deserve a repeat biopsy, and certainly if he had this PSA 6 months later, all the more reason to do it, even in the face of that negative MR. But to your point about PSA, there's a lot of fluctuation in PSA in men on active surveillance, which kind of limits the utility of PSA even as a monitoring test.
I agree.
Perhaps in the setting of a 5-alpha reductase inhibitor, PSA becomes more meaningful.
So a 5-ARI here I think would be very useful. I've looked at the data on PCA3 in the surveillance population, Jerry, and I have to say I haven't been very impressed that it's sensitive enough to pick up meaningful changes.
No, I agree. We occasionally see significant changes in the PCA3. Not sure what that means.
Yes.
We're in the process of correlating that. But your point about 5-alpha reductase inhibitors is very well taken.
Yeah.
And the other thing is PCA3 is not affected by 5-ARI, so you don't have to adjust it the way you do for a PSA value.
And one other potential advantage of PCA3 is it's not affected by body mass index the way PSA is. And so obese men tend to have lower PSA values. They're harder to do DREs on and so forth. So PCA3 might be a better screen there. Okay, so his repeat PSA was down to 5.3, so he was comfortable. He was rebiopsied at a year. And now instead of 2 cores, he has 3 cores of Gleason 6 disease, still low volume. So the key question here is this biologic progression, true biologic progression, and is he in trouble? Is it time to pull the trigger? Or is this simply migration to low-risk disease instead of very low-risk disease, and what does that mean?
I think he has multifocal, small volume Gleason 6 cancers. He may have 4 or 5 others that you just haven't hit yet.
Yep.
You know, the average radical prostatectomy has 5 or 6 different tumor foci anyway. So I would be very reassuring to him.
Okay, you're still comfortable following him. He
am.
says, Dr. Stevenson, I know you're an advocate of active surveillance, but I've got more cancer on biopsy now. Isn't my cancer progressing?
I would tell him that this is reflective of what his cancer was, a year ago.
Okay.
We just didn't identify it on the initial biopsy.
Okay, so this is undersampling, you think?
Yeah.
All right, so let me ask you this. Let's change it a little bit. Let's say he had a Gleason's 3+4 this time, one core, 2 cores of 3+3 and 1 core of 3+4. Is that biologic progression?
I think it's just the vagaries of a different biopsy,
Okay.
personally.
I think that's a great question about how soon does evolving prostate cancer manifest itself when you're doing biopsies, and I suspect it probably takes several years for you to appreciate.
It still could be
anything.
undersampling, though. He could have.
It is undersampling.
Well, that's to my point. In terms of progression, I just think
Right.
I like the term reclassification because I just think we're appreciating better just because we stuck more needle biopsies.
So, any other
cancer.
adjuncts you want to consider now that could help answer this question for him? Adjuncts to
Well,
biopsy?
he could undergo genetic testing if he was concerned.
Okay.
Sure.
Or a repeat MR.
Yeah, actually,
Or
I'm
repeat
routinely getting
MR.
MRs prior to my repeat biopsies.
So I saw this man just as the genomic health test came on the market, and this was sent off there. And he started in the very low risk category, and biologically now he's in the intermediate risk category. He's 53 and healthy, which means he has a long life expectancy. And the genomic test would suggest that he has a 65% chance of not having dominant pattern 4 disease or disease outside the prostate. What now?
I mean, I think that
Is that good news or bad news?
Well,
or worse than
I
this?
think it's suggesting that he doesn't have a trivial, indolent, multifocal Gleason's cancer. He has something that may potentially harm him. So I think that this is useful information not only for him but also for the physician treating him, and it may be appropriate to reconsider staying on active surveillance, pursuing treatment, but or it may simply mean you're going to monitor him more intensively going
Right,
forward.
and I think either of those are reasonable. What do you think, Joe?
No, but I do think that was an impactful move,
Yes.
from very low to
Yes.
the beginning of
Yes.
the intermediate range.
And again, I would just emphasize it's early with these tests. This moving risk category like that doesn't happen that often. It doesn't happen in many patients. But again, I would submit that if you're that patient, you would want to know, and that's where I think the value is here. So he decided to go ahead and be treated based on this, and his prostatectomy showed Gleason's 4+3 disease with focal extraprostatic extension, but otherwise favorable. So he likely is cured, and the question remains, could he have been followed a while longer and still have been cured down the road? Would we have been able to pick up what we presume was a progression to a more aggressive disease? We simply don't know the answer to that question. But it sort of illustrates, I think, all the adjuncts that we have available to us. PCA3, there's a genomic test called MDX, Confirm MDX, that can also be used in the negative biopsy setting, and any of these genomic tests that could inform a decision on whether or not he needs to be treated.
A rapidly expanding diagnostic landscape.
Yes.
Very
Well put.
good. Well, that was really interesting, and I think it's obvious that this field is growing and evolving rapidly, and I'm sure that with time, these gene expression profiles, genomic tests will become more refined and more sensitive and provide even better information. Very good. Well, thanks to all of you for participating. This was
Thanks very much.
very interesting. I learned a lot. I hope all of our friends out sitting in front of their laptops learned a lot too. So thanks so much. And thanks to all of you for watching this Doc Talk, a discussion about screening, risk assessment, and active surveillance for prostate cancer. Thanks again.